I'm very excited about Breastlink coming to New York. It's a very exciting opportunity for us to be able to bring this organization to New York, and I think it is one that the patients are going to love. The association with the radiologist is going to be a wonderful association, and I'm very excited to be part of this endeavor. All patients who come to the breast center get risk assessment. Risk assessment is a very important part of the management of patients and often can change how we manage them in the future. So when a patient comes in, we look at a lot of different factors, such as their family history of breast cancer and ovarian cancer, as well as other cancers, their age of menarche, their age of menopause, their use of hormone replacement therapy, as well as other factors. From all of this data, we can assess whether a person is at an increased risk of having breast cancer or at an increased risk of having a genetic mutation. If we do deem them to be at an increased risk, we may change the management of these women. This change in management can include the addition of more breast exams. It can include the addition of ultrasounds and MRIs to their annual mammogram, as well as the addition of genetic testing to see if they are a carrier of a genetic mutation that may increase a woman's risk of breast cancer. If a woman is deemed to be at an increased risk for carrying a gene mutation, we have them have a consultation with our genetic counselor. At that meeting, the genetic counselor will sit down with the women and gather all of their family information and map out the entire family tree. So this will include looking at both the mother and the father's side of the family and all the cancers. Once we determine what the family tree is, we decide who is the best person to get genetic testing. The test itself is very simple. It's a blood test that will look at a bunch of genes to see if they are a carrier of any of these mutations. If a woman is a carrier of any of these mutations, then we can discuss what different management options are available to them. It is very important for young women to remember that a woman of any age is at risk of breast cancer. If a woman notices a change in their breast, this can include a mass, redness of the breast, bloody nipple discharge, crusting of the nipple, a change in the contour of the breast, or other changes. They should never be afraid to go to their doctor to have these changes assessed. It's also important to remember that most of these changes are not going to be associated with a breast cancer, so they should never be fearful to come and to discuss their concerns with their doctor. So a young woman, as I said, should always do a breast exam. They should be doing this every month. The best time to do it is right after their period is over. That would be a full examination of both breasts as well as the armpit area. If they notice any changes or any masses in any location, they should come and see a doctor about that. Also, it is encouraged that you do see a doctor once a year to have a clinical breast exam. We don't start imaging until somebody is 40 years old, unless they have a family history of breast cancer. If they do, we start mammograms 10 years before a first-degree relative with breast cancer. Over the years, we have discovered that less surgery is sometimes more. So that many women who do have breast cancer, especially if it's a very small breast cancer, we can treat them with breast conserving surgery. That would be a lumpectomy, which is removing a cancer with a very small area of normal breast tissue around it. We sometimes have to remove lymph nodes as well to see if the cancer has spread. There have been improvements in that field as well. Often we only have to remove 1 or 2 lymph nodes from the armpit area, and we do not have to remove any more lymph nodes than that. Now, if the breast cancer is more advanced, we do sometimes have to do mastectomies, and there have been great improvements in that. We can often do a skin-sparing mastectomy, which is leaving all of the skin and just removing the breast tissue from underneath. And then we do reconstruction at the same operation. In addition, we often can do nipple-sparing mastectomies, which is through a very small incision. We leave all of the breast skin behind, we leave the nipple, we leave the areola, we just remove the tissue from underneath, and the plastic surgeon can then come in and reconstruct the breast at the same operation. So the cosmetic results have vastly improved over the years, and there are a lot of options available to women for the treatment of their breast cancers. Breast cancer spreads in a very predictable fashion. It starts in the breast, and from there it goes to the lymph nodes in the armpit area, and from there it can go elsewhere in the body. So when a woman is diagnosed with breast cancer, we usually have to remove a lymph node or two from the armpit area to make sure that the cancer has not spread. We do this with a technique called sentinel lymph node biopsy. A contrast is injected into the breast, either the day prior to surgery or the day of surgery. This contrast then goes to the lymph nodes in the armpit area. We have a special machine that we can use during surgery which will identify those 1 or 2 lymph nodes that have taken up the contrast, and we remove only those couple of lymph nodes. Those are called the guardian lymph nodes of the breast, and that's where the term sentinel comes from. If those lymph nodes are free from cancer, we do not have to remove any more lymph nodes from the armpit. Now, this is very beneficial for women in that it decreases a person's risk of getting swelling of the arm, and it decreases post-op pain or discomfort. So that has been a huge advancement in the treatment of breast cancer. When treating breast cancer, we specialize in tailoring our treatment to the breast cancer. We tailor the treatment that somebody gets to the actual biology of the cancer. So it's not just the size of the cancer, it's not just whether it has spread to the lymph nodes, it's the actual biology of the cancer. So we have special tests that we can run on the cancer itself to see whether it is an aggressive cancer or whether it's not an aggressive cancer, and we will base our treatment options on that. Now, the treatment options that we will decide between is whether surgery is enough, whether we need to add chemotherapy to it, whether we need to add anti-hormonal therapy, and whether we need radiotherapy. So there's been a lot of advancements in the treatment of breast cancer. It's not one size fits all now. It's absolutely tailored treatment to the cancers. So women should begin their annual mammograms starting at the age of 40. This should be done every single year once a woman turns 40. If a woman has a significant family history, which would be a first-degree relative with breast cancer, we start annual mammograms 10 years before the first-degree relative. The only time this would change is if we do have a genetic mutation in the family. Then we start mammograms at the age of 25. Now, sometimes we add additional screening to the mammograms. If a woman has dense breasts, which means they have more breast tissue and less fat in the breast, then we can add annual ultrasounds or sonography to the mammograms. This is just another way of looking at the same tissue. If a woman does have a genetic mutation or a very strong family history, we can add MRIs once a year to their screening. Again, it's just another way of looking at the same thing, and it's the best way of picking up breast cancer at its earliest and most treatable stage.